Welcome to the CHCH Newsmakers podcast. I'm Rick Zamperin. If it's making news in Hamilton, Halton, and Niagara, across Canada or around the world, you'll find it here on Newsmakers. Researchers at St. Joseph's Healthcare Hamilton have received nearly $1 million in funding for research to help loved ones mitigate symptoms of those living with one of the most disabling medical conditions, obsessive compulsive disorder, or OCD. Joining us on Newsmakers is Dr. Rowa from the St. Joe's Anxiety Treatment and Research Clinic. Thanks for joining us today.
You're very welcome. Thanks for having me.
So this is a 4-year study. It comes with a boatload of funds.
Yes.
What are you going to be looking at?
Well, we're going to be looking at the study is co-led by myself and my colleague, Dr. Noam Sereni, a pediatric OCD psychiatrist. Mm-hmm. And we've been interested in supporting the family members of people with OCD in terms of reducing the level they accommodate the disorder or the symptoms. So lots of times people who live with or love someone with OCD are really just trying to help their loved one, make them feel better. So sometimes they inadvertently start participating in some of the OCD demands. So we've been looking at how can we help support, educate, and coach the family members to not do that. So we've been running a lot of work, some pilot work, and we've been getting a lot of success with the family members. And now this study is going to take it up a notch and see if that intervention actually really has big payoff for the patients as well.
Right.
So we're going to be working with family members, and some family members are going to be receiving this intervention, and the other family members are going to be receiving the same amount of pure education, and we're going to see the impact that both of those interventions have, not only for them as the loved one, but also for the person who's struggling with OCD.
Oh, it's really interesting. Do you have a working hypothesis on how it's going to play out?
Well, we love this study because Noam Sereni and I, we decided it's a win-win, because our hypothesis is that this intervention, where we're really actively coaching people to change the accommodation behaviors, we think that's going to be more impactful for the loved one as well as for the person with OCD. But even if just the education gives people a boost and really helps the loved one, helps the person with OCD, we're very happy with that as well, because both of those interventions are pretty easy to teach clinicians and pretty easy to share broadly so that we can support families as well as the people with OCD.
And why a 4-year timeline? Is that a specific number that is needed to get the results that you want to see?
You got it.
Okay.
Because we're going to be randomly assigning the family member to get one of two interventions, we just need a lot of people to make sure that we can really see if one does outperform the other in the long run. So we just need a lot of people, and so we thought, let's give ourselves enough time. So we asked for 4 years of funding, which the Canadian Institutes of Health Research was very generous to provide for us so that we can run this study properly.
Okay, we'll get into the recruitment a little later on in our conversation, but I do want to ask you, OCD, what is it? Because I think there might be some misconceptions on how it works or who has it.
It's a great question. So OCD, obsessive compulsive disorder, it's a mental health condition, and it's characterized by unwanted intrusive obsessions. So thoughts about things that people don't want to think about, intrusive thoughts about being contaminated by germs, intrusive doubts about whether I locked the door or turned off the stove this morning, intrusive repugnant thoughts about, violence or acting out sexually in ways that the person never would. And those thoughts are very, very uncomfortable and anxiety provoking. So the other part of OCD is people engage in a lot of behaviors like compulsions or rituals to try to make sure nothing bad happens or to try and feel a little bit better in the moment. So people might wash their hands excessively. They might go back and check things over and over again to try and relieve the doubt that they may have left the stove on, which would burn down the house. They try to suppress or push away these uncomfortable, violent thoughts that are really horrible to them. And then they get caught up in a loop where they spend sometimes hours and hours a day trying to manage these unwelcome, unwanted obsessions.
So this is way more than, for example, being a neat freak and having something a certain way. This is debilitating, right?
It is debilitating, and it's more severe. It's in its most severe forms. It is one of the top 10 worldwide medical conditions in terms of disability. So it is taking up hours and hours of people's days. Sometimes people can't work. It has massive implications on relationships, so it can be incredibly disabling.
How do you know that you have it? How is it diagnosed?
Yeah, it's diagnosed with a mental health specialist, so a psychologist, a mental health clinician, a psychiatrist, a family doctor with mental health experience, where we really go through a whole bunch of symptoms and try to find out how much people are having the particular symptoms, how much time it's taking, how much those symptoms are actually getting in the way of their goals and their values. And then all of that together helps give a picture of whether somebody may have a diagnosis or not. Sometimes we give people questionnaires as well that help us get a little bit more information about the details. It can be very hard for people with OCD to share all of their unwanted intrusive thoughts, especially the ones that are about violence or sexual topics that are so uncomfortable for them. So sometimes we do questionnaires to kind of add to that information so that maybe people feel a bit more comfortable sharing some of those more distressing personal obsessions and compulsions.
This might seem like a weird question, but is this hereditary? Does it run in families?
It runs in families, yeah. There's a really significant genetic component. About 50% of our understanding of OCD is genetics. So that means that 50% is not. 50% is all sorts of other things around our learned experiences and our personalities that might increase our vulnerability. But yeah, about 50% can be explained by genetics, which means when we talk to parents with OCD or having kids and they're nervous, will my kid definitely have OCD? And the answer is no, they won't definitely. But we do see it running in families. We do see a sort of a thread through a family history.
Right. When, and I'm talking by age, when is it figured out that a person has OCD? Are they in their teens? Are they younger than that? Does it come in adulthood?
There's two common ages of onset. One is childhood.
Okay.
So early on, we can see this. And actually, in childhood, there's a greater number of boys than girls who have a diagnosis of OCD. And it's usually picked up by seeing the behaviors, the compulsions, the rituals.
Right.
And we don't want to overdo our diagnosis in childhood because lots of kids have rituals and they have, sort of ways that they do things and they have little routines that they want to stick to and then they outgrow it. It doesn't become anything problematic. But we certainly can see when kids start getting really stuck and spending a lot of time on their rituals, that's a good indicator. The second most common age of onset is sort of early adulthood. So that's when we see equal numbers of men and women, and the person starts to have a lot of more time-consuming symptoms. Maybe they had a few symptoms when they were younger, but they really start to sort of get more strong, more time-consuming, more problematic in early adulthood.
Do we know why younger boys are more susceptible, if I can say that, to younger girls?
We don't. It's probably genetic. There's probably some more heavy emphasis of the genetic component. When kids get OCD, there's probably a very strong genetic influence, and then maybe the genetics and the environmental things start to even out as people get older, but we don't know for sure.
Yeah. What is the long-term prognosis for somebody who has OCD that doesn't seek treatment? What happens to them?
People who don't seek treatment, their OCD will wax and wane through their whole lives. So it doesn't go away, but it's not necessarily something that's going to be sort of chronically awful for their whole lives. It kind of goes up and down. And, there's been some interesting research trying to figure out why does it go up and down, but we don't fully know, but we have some clues. It tends to increase when people have increases in responsibility. So when people, for example, buy their first house or move into their first apartment, all of a sudden they have this new level of responsibility. And we know that people with OCD tend to have really high levels of responsibility, like actually maybe too high levels. They take on a lot of responsibility. They feel very guilty for things that they maybe should have noticed and fixed, things that you and I might ignore and not worry about. So that increase in responsibility, a brand new job that has a higher level of responsibility. We also know having your first child. And we used to think it was hormonal, so moms more than anything, but we know now that actually new dads, they also have a spike in potential for OCD symptoms to exacerbate if there's other vulnerabilities. So we know it's not all hormones. It's something about that experience. So the hypothesis is probably it has something to do with the incredible responsibility we feel when we have our first child. And then the other thing that's really important that sort of helps us understand the waxing and waning course would be stress. So increased stress of any kind really does play a role in increasing symptoms of something like OCD.
What about treatment? What does that look like?
Yeah, there's tons of really, really helpful treatments for OCD, which is very encouraging. It's very nice to know that we have many good options. The two first-line treatments are antidepressant medications and then cognitive behavioral therapy, which is what we're offering in this study. We're going to make sure if people are on medications that we kind of keep them on the medication medications at the same dose. So that's not the thing we're looking at, but we're treating them with cognitive behavioral therapy, which is a form of psychotherapy that asks people to gradually and gently expose themselves to their OCD triggers, but then not do their rituals or compulsions, so that they can learn that nothing terrible happens, that the anxiety that they feel about an obsession might fade away over time, and they don't have to do anything extraordinary to fix it, that maybe they can tolerate a little bit of like, I'm pretty sure I locked the door or turned off the stove, but nobody's perfectly sure. And maybe that becomes more comfortable for them over time. So cognitive behavioral therapy is the therapy of choice for people with OCD.
So in essence, are you teaching them a learned behavior? Okay.
Yeah, that's a great way of putting it. We're trying to teach them and help them learn on top of a partially learned set of behaviors, right? People with OCD, when they do their rituals, they get temporary relief.
Right.
That is incredibly powerful at reinforcing that behavior. So if I felt a little relief when I went back and checked my stove 10 times, then I am really likely to do that again. It's been reinforced because I felt this settling of all this tremendous anxiety that I had. So we're reteaching that. We're helping them learn new information that maybe the anxiety goes away on its own. Maybe they don't need to check because there was really nothing bad that was going to happen. Maybe they can trust their own memory that they probably checked it or turned it off and it's probably fine.
So it's kind of like you're unlocking a feeling that they feel when they do the behavior. Right.
Yeah, we need them in therapy to have the feeling, that little bit. We want to dose them with a little bit of the anxiety. Not a ton. That's really awful for people. We don't want to do that.
Yeah.
But a little bit of the doubt, a little bit of the distress, a little bit of an uncomfortable, ooh, that just doesn't feel right. We want to dose them with that a little bit on purpose and still have them not engage in the OCD demands, those compulsions and rituals, so that they really can learn that they can tolerate it, that they can manage without any of that OCD rituals and rules.
What's the plan to measure how it's working along the way?
Yeah. So we're going to measure a number of things at a number of time points. So we're going to measure for our family members, we're going to measure how much they're engaging in what we call accommodating behaviors, which are things like providing excessive amounts of reassurance when somebody's in the middle of an OCD spiral or loop. We're going to measure how much they're waiting for people because they're engaged in OCD compulsions, even though it was time to go to a family event or sort of an outing. So we're going to measure those behaviors in family members along the way. We're going to measure how much they feel that they understand OCD through these sessions that we're going to offer the family member. And then for the person with OCD, we're going to measure their symptoms, their OCD symptoms. We're going to measure the amount they see these behaviors from their loved ones, so their perspective on what's going on with their loved ones. And we're going to measure their quality of life and how much they're functioning and how much the functioning improves as they go through therapy. So we're going to measure all those things at multiple time points along the way. And then again, we're going to follow up our clients with OCD for 3 months after they finish treatment to see how they're doing down the road, because some of these effects could actually start to even improve after they finish therapy. And the family members not accommodating their OCD anymore and just providing really good support to them. And they're not engaging in all these rituals and to the same degree. So we're going to follow them up for 3 months to see how they're doing and measure all those variables again.
Yeah. And that's what success is going to look like if you see those differences, right?
Yeah. We're really excited to see how much this impacts the person with OCD's functioning, quality of life, how much that really helps them. And then also we're going to look at a few variables around how the family is functioning, because we imagine that the intervention is going to help lift some of the stress that happens in families with one person is really struggling with OCD and the other person doesn't quite know what to do, what's the right answer about how to help them. And then sometimes when they accommodate, the person might get frustrated. They get tired of waiting. They want to understand that this is because of the OCD, but they're also late to things and they're being asked the same question 10 times. And so as human beings, it's natural that we get a bit frustrated with that. So we're really going to equip the family members, we hope, with lots of information and lots of skills to be able to have a plan of how to respond to the person with great support and empathy, but not the OCD.
So at the end of the 4 years, is one of the goals to say, okay, this is definitely something that works folks in most cases, if not all, and we should concentrate on this.
Yeah.
Okay.
It is exactly right. The goal is looking at this intervention to see, does it actually help people more than just providing the loved one with information? And if it does, then to really basically make that available to the entire community of people who support people with OCD. So trying to really share that with clinicians, with researchers, with support groups for family members of people with OCD, to kind of spread the word as broadly and loudly as possible about what might actually help family members best support their loved ones.
And this would not replace those with OCD who are on medications. This would be a supplemental healthcare component.
You got it. We are taking people in this study, even if they're on medication. If the medication's helping, we're very happy about that. A lot of people with OCD benefit from the combination of medication and therapy. So we love that combination for people who choose to go down that route. So people who are on medication, we ask them, stay on your medication. Just don't go up and down on it, because that can introduce like other changes about why they might be feeling better or worse with their symptoms. We want to just make sure that that part stays constant so that we can add in the family intervention and then the therapy and really see, does that, how much does that really add and help the person with their symptoms?
As far as recruitment goes, I know this is a little bit down the line, but what are you looking at and when do you hope to start it?
Yeah, we are. So we're sitting here in February, and we just found out we got the funds, so we're very excited. But we have to have a big ethics process, because it of course is very important that this study is been reviewed comprehensively by our research ethics board, that we're recruiting ethically, that we're doing everything in a way that is very much approved by our ethics boards. So that takes a little bit of time. We're probably going to start actively recruiting in the fall of 2026.
And so you're looking for upwards of 200 participants?
Yeah. Okay. And we have a partnership. We have a wonderful crew at the Sunnybrook Frederick Thompson Centre in Toronto at Sunnybrook Hospital. And they have researchers and clinicians there that specialize in the treatment of OCD. And our team has worked with their team in several other studies. So we're continuing our collaboration. So they're going to be also recruiting in Toronto. And we're going to be recruiting across our entire West region, Hamilton and beyond, for anyone with OCD who lives with a family member. We want them to be able to have lived with their family member for the past year at least. Most people live with their family members for much longer than that. And anyone who meets that bill and is interested in coming in and receiving therapy, and the family member is willing to come and receive some individual sessions before the therapy starts, we're going to invite them into the study.
And are you just looking for adults at this point?
Just adults at this point. In fact, the pediatric OCD world is 3 steps ahead of us. They always incorporate family work. Some of the best treatments for OCD in kids is actually going through the parents and providing support and intervention and therapy to the parents, or to the parents and kids together. So the pediatric world really knows that families matter and are important. I think in the adult world, we're catching up now, finally, to realize, it's really important for adults as well, especially, adults with OCD who are living with, young adults living with parents still, partners of people with OCD, siblings who might live together of people with OCD. Like we've neglected them for too long. So we're finally addressing that and wanting to really look at that level of support. And in our pilot work with family members, they have been amazing and grateful and a huge asset, I think, to supporting their loved ones. So we know that there's an appetite for the family members. They really want to be involved. They want to know what's the right decision. They want to be guided with really good information about how to best support their loved one. 4
years from now, what do you hope this reveals?
Yeah, I hope this reveals that spending some time with family members, no matter what it is, whether it's providing them with education, or whether it's a full intervention like our intervention with coaching, I hope it reveals that actually gets people with OCD further along in their treatment, a better outcome in their treatment than if they just did it in isolation. So I hope that we learn that something about supporting the families in this way actually does make a big difference, and then we can really, broadcast that message loudly and broadly.
If someone feels that they have OCD but they don't quite know what it is or how it works, where should they reach out to?
Well, they can do a couple of things. I think as a first step, there's a wonderful set of web resources on the International Obsessive Compulsive Foundation website. So it's an international organization focused specifically on supporting and researching and providing services and education for people with OCD and their loved ones. So that's actually great information. So it's an easy Google search for the International OCD Foundation. So people can, read the information, see if it feels like it really does fit. And then if they do feel, either through reading that information or just because they kind of have a sense that they might have OCD, the next best stop is through your family doctor. Have a chat with your family doctor, and the family doctor is a gateway to a bunch of amazing resources. So, for example, here in the Hamilton area, we have the clinic I work at, the Anxiety Treatment and Research Clinic at St. Joseph's Healthcare. We have specialized services for OCD, so we welcome referrals. We can do the assessment and actually ask that question, figure out, do you have OCD? Do you have a different anxiety difficulty? We have many, many therapy and medication options that we can help support people with. Here in the West region, but also across the province, there's a program called the Ontario Structured Psychotherapy Program, or OSP. OSP offers free cognitive behavioral therapy for anxiety, depression, OCD, stress, and coping for any adult in Ontario. It's completely free, so people can go to their local OSP, wherever they live in the province, and they can be assessed for various forms of cognitive behavioral interventions for things like OCD. And so there's just amazing services out there to really support people if they're looking for some help.
Tons of resources. That's great to hear.
Yeah.
There was a very recent post by Hollywood actress Jenna Ortega who confirmed that she has OCD in a very serious case, according to her. What does someone like that at her platform, given her platform, kind of do for the OCD movement, if I could put it that way?
It's incredibly helpful. There have been a number of sort of high-profile celebrities who've come out through the years and talked about their battle with OCD. I'm going to tell you one of them that's very surprising when I share this with people, Howard Stern. So, he's talked for years about his struggles with OCD. Jenna Ortega, it's just incredibly important. There still is a stigma. There still is a misunderstanding about what it is and isn't. So having people who are incredibly successful, smart. I mean, our clients with OCD are successful, smart, interesting people. They just happen to have OCD. And so really having people out there who are willing to say, I struggle with this, is helpful because it destigmatizes. Maybe it helps somebody else feel like, ooh, maybe that's something that I can ask for some help for. Right. And then really publicizing the idea that there are many treatments. I talked about the 2 first-line treatments, medication and cognitive behavioral therapy. But there are other treatments beyond that. If those don't really work for people or don't work to the full effect, there's some neurostimulation treatments that people are researching. There's just many other options. So we really want to encourage our clients with OCD to know that it is a common problem. It means nothing. I was going to say it means nothing about your, who you are as a person, but in fact, it actually means something because the intrusive thoughts that people get stuck on are the ones that violate their morals and their sense of self. So if they're having an unwanted thought about something aggressive, it's probably because they value being a peaceful, kind, supportive person. So it just gets sticky and they get upset by that. So it actually tells us that people with OCD really are, they have kind hearts, they want to do well, they're very responsible, and so they have symptoms that are really taking advantage of those wonderful qualities. Fascinating
conversation. Congratulations on securing the funding. Best of luck with this project. We'd love to follow up 4 or 5 years from now to see how it all panned out, and I appreciate your time this morning as well.
Wonderful. Thanks for having me.
All right, and thank you for joining us. And thank you for the all-star cast behind the scenes and for checking out the Newsmakers podcast as well. If you like today's episode, click the thumbs up, hit subscribe, leave a comment. You can catch the Newsmakers podcast on chch.com/podcast and wherever you get your favorite podcasts.